Well, quercetin is one of my go-to nutraceuticals, and I always like to think of it as an antioxidant and an anti-inflammatory agent. So any of my patients who come into the clinic with rhinitis or allergies, quercetin is my go-to as nature's antihistamine, for lack of a better description. It is also my go-to as an anti-inflammatory, and I frequently use it in combination with other agents like curcumin or boswellia or bromelain for people who have symptoms of arthritis and joint inflammation. And then, of course, we also know that quercetin downregulates NF-kappa B, and in doing so, it really helps to push down those pro-inflammatory cytokines, and it works as an antiviral agent as well. So in my current antiviral protocol, I have incorporated quercetin. I pick my phytonutrients based on someone's need. I try to personalize nutraceutical support utilizing a Nutrieval where I can really look at what someone is missing. So, for example, the B vitamins may be fundamentally important in homocysteine regulation. So, B vitamins for people that have elevated homocysteine are a key ingredient for cardiac health. Antioxidants for endothelial function. If someone has low levels of antioxidants, I will give them back the vitamins that they need, whether it's alpha lipoic acid, vitamin C, or a mixed tocopherol combination of vitamin E. I do use also a lot of omega-3 in my practice, particularly EPA, because it does have anti-inflammatory effects and has been shown to lower triglycerides. And of course, vitamin D is fundamentally important for me because people with low vitamin D levels tend to have more cardiovascular disease and more cardiovascular risk factors such as diabetes. So again, I like to personalize it, and I also like to do a endothelial function test such as an endopat, and if I find that the nitric oxide is low and the endopat, the RHI is low, I may also use beetroot extract, which is an excellent source of nitric oxide stimulation. Stress and aging are kissing cousins, right? So if we look at any U.S. president, for example, they start out with neutral color hair and they have white hair by the time they leave the office. That's classic oxidative stress. And we know that as cortisol goes up and DHEA goes down, we start to see all of the parameters of aging. So that could be anything from diabetes to central weight gain to osteoporosis to immune dysfunction and so on, sleep disturbance, everything that goes along with hypercortisol levels. So the first and foremost thing I recommend is that people really look at their life and incorporate a practice that promotes decreasing the stress response. And that can be anything from walking in nature to learning transcendental meditation, which has a 48% reduction in cardiovascular events, to learning mantra repetition or going to a yoga class, whatever someone wants to do in that arena. Calorie restriction has been shown to decrease the aging process. Mindfulness-based stress reduction has been shown to increase telomere length and increase telomerase. I like to use many bioactive nutraceuticals, and these may include berberine, which affects the NFR2 pathway, also affects cholesterol and blood sugar levels, resveratrol, may use omega-3s, and of course I like to use calorie restriction, and of course meditation. All of these things can impact the aging process. So one of the things we forget about the gut is the gut has a full immune system, and the gut is the largest producer of serotonin. So we know that there's a constant signaling between the gut and the brain, whether it's through the production of 5-HT, which goes on to produce serotonin production itself, cytokine production, and even the vagus nerve pathway from the heart to the brain, which gets affected by the GI tract as well. So, for example, if I have a fight-flight reaction and I send a signal via my vagus nerve to my brain, I'm going to start to produce stress hormones, which are immediately going to have an effect on my microbiome. The latest research shows us that stress impacts the microbiome. If my microbiome is producing inflammatory cytokines, we now know that there's something called cytokine sickness, which looks just like depression, fatigue and depression and malaise and so on. So if we don't fix the inflammation in the gut and we don't help people to regulate their autonomic nervous system through breath work, through meditation, through yoga, through all of the things that we can do to impact the autonomic response, we affect the microbiome, which ultimately affects the brain, ultimately affects the heart. Biomarkers for heart health, I think, have to begin with inflammation. For many, many years, we talked about cholesterol, but the conversation is now all about inflammation. So everyone in the office today can measure an HSCRP. The research shows that an HSCRP less than 1 has less cardiovascular events, even at the same LDL level. So if someone's LDL is 70 and their HSCRP is less than 1, and someone else's LDL is 70 and their HSCRP is greater than 2, that person has an increased cardiovascular risk. So HSCRP is a simple one. LPPLA2 gives us some information about arterial inflammation, and if it's elevated, it's an independent risk for a cardiovascular event. We can also measure MPO, myeloperoxidase, which is released from the white blood cells. And some of the latest research is showing us that looking at MPO and other more novel markers like high sensitivity troponin, troponin T, ceramides, these are all going to be the new boys on the block that are going to tell us that people are at a higher risk for having a cardiovascular event. But before you go on to some of those, you might want to just think very simply about HSCRP, MPO, LPPLA2. You may want to look at fibrinogen because fibrinogen still remains a marker for inflammation. And then you want to look at a few different things within the lipid profile. You want to know the LDL particle number. How many LDL particles does someone have? You would like to know, does someone have small, dense LDL? And remember, if the triglycerides are high and the HDL is low, you most likely have small, dense LDL. You want to know the HDL particle number. That's become a new boy on the block. The higher the HDL particle number, the decreased risk. So we like to see the HDL particle number up and above 33. That's our cutoff. We also want to measure Lp(a). Lp(a) is a genetic independent risk factor for cardiovascular disease. So we have the inflammatory markers on one side again, HSCRP, LPPLA2, MPO. Those are sort of the basic ones. You may also want to go to look at fibrinogen, and you might even want to look at a marker of microbiome change, which is linked to cardiovascular disease, called TMAO. And then as we go into the lipid profile, again, you want to look at LDL particle number. You may want to look at ApoB, which is surrounding all of the atherogenic LDL particles, IDL, VLDL, ApoA1, which is part of the HDL molecule. Look at HDLP, HDL particle number, and that will give you a nice sort of layout of the basic lipids. And of course, you want to make sure that someone does not have hypothyroidism, because hypothyroidism will affect the lipid panel. You want to make sure that we don't have Hashimoto's thyroid antibodies, because that will affect the thyroid, which can then affect the lipid panel. And then you also want to look at the markers of metabolic syndrome. So you want to look at the triglycerides, you want to look at the fasting blood sugar, you want to look at the hemoglobin A1C, and you want to look at the fasting insulin level. And I think if you can get through those right up front, and maybe do a NutriVal, so you get your vitamin D and you look at your omega-3 check and micronutrient deficiencies, as well as heavy metals, you'll have a whole layout of looking for risk for cardiovascular disease. So when I see a patient in my office, I'm always concerned about their GI tract. And the reason I'm concerned about their GI tract is because that's a potent source of inflammation. And as we see over and over in the literature, inflammation is linked to cardiovascular disease, as well as cognitive decline and a host of other problems. So if someone says to me, I'm having stools alternating with diarrhea and constipation, or I see food in my stool, or I have gas and bloating, or I have heartburn, of course the first thing I'm going to do is look at the diet. And I'm going to go after the common culprits. Maybe something like sugar, which is a potent source of inflammation. For some people, it may be dairy. But with that patient sitting in front of me in the office, I know before I even address their lipids, I have to fix their gut. And so what I will do at that point is a elimination diet. And I explain to the patients with a simple handout that I'd really like you to stay off of gluten, stay off of dairy. Those are my two big ones right up front to start. Of course, there are other foods that can be pro-inflammatory, like eggs and citrus and tree nuts and so on. I will put them on a cleanse, if you might, which would be a smoothie that contains high phytonutrient protein, and I will use that while I'm putting a patient through an elimination diet so that I'm sure they're getting their multivitamin, they're getting the protein that they need. And during that time, I am then looking at a food sensitivity test, which takes about 2 weeks to come back, a 3-day stool test, which takes about 2 weeks to come out, and I'm waiting for their Nutraceuticals. And if I suspect that what's going on in their GI tract is related to stress, I may also look at an ASI, an adrenal stress index, 24-hour cortisol. And then when they return back to my office, I can put all the pieces of the puzzle together. Now, if someone says to me they have bad heartburn, I am going to look at the underlying causes of heartburn, for example, and then I'm going to put them on Nutraceuticals that clearly can improve gastrointestinal heartburn symptoms. And this may be anything from slippery elm to a host of other agents, DGL, and so on. And if I feel that someone has been exposed to lots of antibiotics, I may reach for even before I get the stool test back, a probiotic, and I may also use a product high in L-glutamine to help to heal the gut. So the protocol is just like we teach in functional medicine. It's really about eliminate what we think is the problem, rebalance, bring in what we think we need, what are the right foods, do we need digestive enzymes, do we need to support the small intestine with butyrate, re-inoculate, do we need to bring in the right kinds of probiotics and prebiotics, repair the gut with nothing better than high doses of L-glutamine, and there are many products that can fill that gap for you, and then make a decision about anything else based on your stool sample. So dairy is an interesting question because, of course, dairy is a full-fat food most of the time, and many people, as we get older, develop a sensitivity to dairy. So I'm not against dairy per se, but if someone says to me every time I have cream or every time I drink milk, I have irritable bowel and I'm running to the bathroom, then I know I'm dealing with someone who obviously has obvious lactose intolerance. Or if I have someone who has recurrent sinusitis, I'm going to check that person for dairy sensitivity, particularly cow milk sensitivity and casein, and whey. So that's what I'm interested in. So I don't take away dairy unless I have a reason to take it away. However, I will say this. Many people live on bread and cheese, and if LDL is elevated and I do want to get the LDL down, then certainly I'm going to encourage them to get rid of their bread, which is just giving them high glycemic carbs. But I have found that if in my big cheese eaters, just eliminating cheese in the diet and reassessing the cholesterol in 3 months, their cholesterol can drop 30 to 50 points. So if that means the difference between a drug, I'm going to say let's eliminate the cheese and do it by diet.